you everyone for joining us tonight. My name's Katie Pryor, and on behalf of the Western New South Wales PHN, I thank you for taking time out of your busy schedule to join us for this meeting. I'd just like to start with an acknowledgement of country, and I'd like to acknowledge the people of the Wiradjuri Nation as I'm sitting here in Bathurst, and all the different nations on which each of our participants meet tonight. I pay my respect to elders past, present, and emerging, and acknowledge their continuing connection to land, water, culture, and community. I extend that respect and warmly welcome all Aboriginal and Torres Strait Islander Australians who are present here tonight. Thank you so much for joining us. Just a little bit of housekeeping before we get started. This is an interactive meeting and your questions and comments are very welcome, but we do ask if you are not speaking that you please mute yourself. We also ask that if you can indicate if you'd like to ask a question or comment, that you virtually raise your hand as is shown here on the toolbar. If you don't want to speak, you can also type your questions in the chat box and we will make sure we cover those as well. Thank you so much to our presenters and panellists for joining us tonight. We're really pleased to welcome back Dr. Ivy Chua and Dr. Melanie Berry, who we have heard from in previous meetings. And we also warmly welcome Andrew Coe, the CEO of Western New South Wales PHN, Dr. Waleed Jamal, who is a GP from the Hills Family Practice, who is currently providing care to COVID-positive children as part of a pilot program with Sydney Children's Network, and also to Christy James, who is the new Manager of Primary Clinical Services here at the Western New South Wales PHN. Thank you all so much for joining us. And I'll now pass over to Dr. Ivy and Dr. Mel to discuss the COVID-19 model of care flow chart in Western New South Wales before we open the floor for questions. Thank you, Ivy and Mel.
Thank you, Katie. I'll start by sharing my screen. So there we go. Is that visible to everyone? GP management of COVID positive patients?
Perfect.
Terrific. So just to set the scene a little bit, 4 weeks ago, we did have our webinar which gave the basics of COVID care in the community that's headed by GPs for low and medium risk patients. There's been further work behind the scenes since then, a little bit of extra information also coming through from the Department of Health as to that initial step there. So I thought we'll just take the opportunity to do a bit of a recap of where we're at the moment. And for those who didn't get the chance to watch the first webinar, we can certainly deal with any questions that are arising on those topics. But let me just magnify that a little bit so you can see a little bit better. So at this point in time, the beginning of the COVID positive pathway really is that the positive result is intended to go to Health Direct, which will be commissioned by the Commonwealth to then do an initial risk stratification for the patient. It will be fairly basic in terms of it will just go to the patient as a text message, which they then respond to. And this is hot off the press from, thank you, Andrew, for filling us in with this one here. So that preliminary text message to do a initial triage will then divide those patients up into likely low and medium risk patients and likely high and very high risk patients. From there, the Health Direct team will connect that patient up with the GP or direct them towards hospital care. The finer details of how that's going to look are yet to be released, and we're thinking they ought to let us know within the next week or so. So from the GP perspective, once we are informed about our patient being COVID positive, we work through then, as per the Health Pathways guidelines, we work through who falls into the low and medium risk category, and we work out some of these people actually high risk and very high risk, in which case, if they're high and very high risk, we refer them straight on to the hospital-led team, COVID care team. So we should be left with the people. I'll go through this in a little bit more detail when I show you Health Pathways in a sec. But basically, we'll be left with the low risk people who are basically between 12 months old and 50 years of age, fully vaccinated, no medical conditions, no social risk factors, i.e. we expect them to be fairly health literate, but also that they don't have any symptoms of COVID or else have very, very mild symptoms with the COVID infection. So that's a low risk people. The medium risk people have got one of the risk factors. So either that they're only partially vaccinated or unvaccinated, or that they're older, so older than 50 years of age, but that all the other risk factors are not present. So with that cohort of people, moving on to the GP care side of things, and this is all written in Health Pathways, so you don't have to remember it. Health Pathways guidelines will continue to be updated if things change. But basically, bird's eye view is our role is to arrange self-monitoring for that patient. So the PHN will be providing oximeters. It's just all we need to do is contact the PHN. For the patients who are medium risk, not the low risk patients, just the medium risk patients, to organise a pulse oximeter to be sent to that patient together with a set of instructions. It tells the patients how to use the oximeter, but also gives them instructions about self-care with COVID infection. Some work is happening at the moment on the PHN front in terms of purchasing a monitoring platform that will then cut our workload by a lot. So thank you to the PHN for moving forward with that. And the idea is that we encourage our COVID positive patient to engage a support person. So a family member or friend who then can make contact with them a couple of times a day and just check that they're okay. So, all this is being put into place with the recognition that GP workforce in Western New South Wales is pretty thin at the best of times, and really needing everything that we can to help support us in our work. So monitoring a platform and that support person, that means that that person will still get looked after, but that we can be a little bit more hands-off. The next step then is the clinical reviews that we do then on a regular basis. And so this is not a hard and fast rule, but according to how you assess whether you assess a clinical need to be. So as a general rule, the patients who are a little bit higher risk, the medium risk patients, perhaps touch base with them on a daily basis to begin with and see how that goes. The patients who are low risk, however, you might only need to touch base with them every 3 days or so. And each of those touch bases, so each of those appointments, which we expect will largely be done via video and phone consultations, it's about checking on the symptoms and giving them symptomatic advice if required. Check that if they've got any pre-existing conditions, by definition, if they're low and medium risk, they shouldn't have pre-existing conditions. But if there is a mild one that sneaks in there, just check that that's being looked after okay. Check that they're adhering to the isolation guidelines and minimising the risk of transfer of transmission of COVID to others in the household. Check that the others in the household are getting tested and that they're also isolating as close contacts. And check on the general well-being. And the idea of all of these checks is that really that if this patient clinically deteriorates, we need to be able to detect that and to escalate the care in a timely manner. And at the end of the journey, at day 14, by and large, for these people, we expect that they should be able to be medically cleared. And there are very strict criteria for medical clearance. So again, that's written into Health Pathways. So no need to remember them, but just click on Health Pathways as you undertake your consultation. So that's it in a nutshell. Post-COVID care, the recognition that a proportion of these patients will have ongoing symptoms. And so just touching base with them making sure that the symptoms do resolve and identifying those people who do need additional allied health input or rehab input in order to be functional and to be, minimise the morbidity. Mel, did you want to add anything to that pathway bird's eye view at the moment?
No, so I think a lot of this is changing very quickly. So I think we should hear from Wally about, so there's a pilot being run at the moment, and Wally's one of our GPs in Metro, and he's working with the Children's Hospital, who have started to work with GPs to see how this kind of care works. But just to say, from the COVID care in the community perspective, so the LHD perspective, that program is planning to continue. And as GPs come on board, there will be a very close relationship, and it's my plan that the doctors and nurses within that community will be very supportive of whoever wants to take on these patients, and we will provide all of our phone numbers, and you can ring us anytime you want to if you have any questions. And it takes just a few days to get your head together around it, but it is very workable. And but we also do recognise that there are some GPs who are very busy, who are single GPs in one town, and we understand that completely, and we understand that rural is different to metro, and that the COVID care in the community will definitely support as we can, and we're very willing to support. But I think it's really useful to hear the experience of some of the GPs who have started to do this. So thank you so much, Dr. Wally, for coming in.
Thank you, Mel. Thank you, Abby. Look, I don't, obviously, I'm in Western Sydney, so it's a completely different environment to where you are, so I'm not going to make any direct comparison as to what's possible. But let me just share, I suppose, my experience with you. Both having looked after adult COVID patients early in January this year with the small Varela cluster, and also now with the Children's Hospital, we're one of 3 practices in Western Sydney that have been commissioned to take over care of children from the Children's Hospital in Western Sydney. To give you an idea of numbers, obviously, we've been doing this now for probably about 6-7 weeks, I think. Half of all children with COVID in Western Sydney are now being looked after by general practice. We're talking 3 general practitioners. And we've had enough capacity in our practice to look after half of those. So it's been a really interesting experience. What made it work, and what did we have to do to really get our head around it is, I think, important, if I can share that. Irrespective, I think, of how you get told about patients, I think you need to, as a GP, be comfortable with a few things. The first is know exactly when you're going to be looking after the patients. In other words, have some sort of handover or take over clinical responsibility for the patient when you accept that patient. Not talking about how they're being sent to you. Let's leave that for another discussion, because that could change any moment. But let's assume that someone has told you about your patient, or a patient that's not your patient that you're willing to take care of. So accepting that responsibility, knowing, right, we are now responsible, this is what we're going to do. The second thing is deciding internally of what we are going to do. And as RV has just outlined, that's clearly outlined in Health Pathways. But each practice will, we formulated our own sort of internal workflows. We said, right, when we get hold of the patients, we get a handover from the Children's Hospital, which is how we're getting them at the moment. It's an email handover. That's a separate issue, but it's an email handover. We've accepted the care of the patient. We create the file in our clinical software. Our receptionists call the patient, put them on our system, and tell them they're going to get a call today or tomorrow from a doctor or nurse in the practice. So we've developed our own internal workflows. We then do a quick assessment about where, to make sure that this patient is actually within our comfort zones in terms of risk level. And then we decide on future care. So we actually then, rebook the patient for a phone call or a video chat, more likely, It could be the next day, it could be in 3 days, it could be in 5 days, depending on how sick they are. We make sure that the patient has our phone number to escalate themselves to us if they've got any problems. We make sure that they've got a pulse oximeter if they do, how to use it. We've already had fact sheets about that, and we also make sure that the patient knows the after hours number, which is provided by the Children's Hospital in our case at the moment. So there's a 1-800 number. The other thing that's made this really work for us is knowing who the Children's Hospital team are, knowing who we can call. And I'm not talking about like a number that you have to wait for half an hour. I'm talking about someone's mobile phone number. It's the paediatrician on call for COVID at the Children's Hospital if we have any trouble. We know who they are, we know how to find them, and vice versa. They know who we are, they know how to find us. They've got our mobile number too. So that working relationship has been absolutely wonderful. Mind you, I think we've had to use it once in about 7 weeks. Most of the communication's been by email, been around administrative issues rather than clinical issues. And then at the end of it, knowing when and how to isolate. So really getting a good feel for the de-isolation process for the patient, what to tell the patient on de-isolation. All of those things are on Healthpathways. They're in the COVID national guidelines, which you need to familiarise yourself with. And otherwise, it's looking after any other patient. It's trying to help them to work out, how they're coping. It's sort of a lot of social support as well. So it's not hard work because most of these patients aren't that sick. If they were sick, they wouldn't be in our care. We did have a few patients previously, particularly adults, who did get quite sick, but that escalation pathway, that predetermined escalation pathway, be it the mobile phone number that we call for help or an ambulance, obviously in extreme circumstances, is really important. In summary, the essential elements that's made the model work for us, both for adults and children, is understanding responsibility, understanding pathways, being very familiar with the COVID care in your community models of care, and what to look for in terms of risk factors, using our clinical judgment, of course, and a very strong working relationship with the local health district team, with whom we co-designed the model. I hope that's helpful. Well, I'm happy to take questions later.
Just to add that for the Children's Hospital, there's been a pathway created as well, a learning tool which is accessible freely, that looks absolutely fabulous, and will provide those links as well. So that's a series of really useful links that they have developed, all about how to look after kids. And I guess we are talking about kids because there are a lot of kids in our current outbreak. And I noticed that Nello is online, and so his community is currently bearing a lot of the brunt of what is happening at the moment in Western New South Wales. And he might be able to share a little bit with us, but certainly we're seeing at least half kids. There's a little smattering of unvaccinated adults, and then the predominant amount is kids plus a few breakthrough infections with vaccinated adults who are generally well.
Yeah, I mean, we're tending to see, multiple households of 10, 11 people, and they just form one by one. And we just pick them up as they go along. We know they're positive before the Children's Hospital do because the parents tell us. And obviously the sick parents, and it's often sort of discussion with the parents about how they're doing, let alone their children. The children are sort of pretty straightforward. Most of them, they get sick, if at all, temperature for a day or two, headache, sore throat, runny nose, and then they get better and start climbing the walls because they're locked up for 2 weeks. So that's been the experience, and after about day 5 to 7 they don't need medicals at all.
Certainly that's what we've seen, and people can also get really fatigued from very regular calls, and so if they're very well, like, they can direct their care. They can say, so sometimes with the more well patients, they'll say, listen, we'll just text you, we're happy, we're fine with that. Yeah.
Yep. In fact, yep, that's exactly right.
Yeah.
Yeah. In certain instances, remember, these people are getting police checks, welfare checks, adult public health, ask for, it's like multiple phone calls, and they get really sick of it very quickly. So don't feel, my message is, don't feel, when you first start, you will feel that you need to be doing something every day. As a GP, I know that's how this works. You need to get your head around it. You need to make sure that everything's safe and that you've got safety measures in place. After you do your first one or two, it will become like any other care that you do. And you do not feel that you as a GP need to be calling these patients every day, particularly the low risk non-symptomatic ones. Just make sure they know your number in terms of where to find you and your practice, and to make sure that the reception team, they're flagged in your system as patients with COVID, so they're not just given a routine appointment for a phone call in 5 days. That's not the care. It's when I ring, I need to talk to someone, and that's where the whole team comes in, from your reception team to your nursing team to you as the GP.
And Wally, if I can just ask, some of the concerns from some of our colleagues has been around after hours care and how frequently someone might need to be tapped on during the after hours period. Can you share? I know yours is going to the after hours number at the kids hospital at the moment, but you're getting a sense from these patients that they're...
Yeah. So for the children, I can tell you, as of our meeting with the Children's Hospital last week, just as a touch base, there were there were almost 200 children who've been looked after in the community by 3 general practices over a 6-week period. 2 phone calls after hours were made to the Children's Hospital team. 2. Right? So that was it. Most of the care was provided by general practice, the 3 general practices. So as long as the safety nets are there, remember, these people are being touched very quick, every day or every second day, and they're given really detailed instructions. They're asked the same questions. How's your headache? Have you got a sore throat? Have you got any shortness of breath? Have you got any chest pain? What's your oximetry? So they start to know what to look for, and they will call, and they're not going to leave it till 11 o'clock at night. And those 2 patients that did call were simply fixed by very simple advice after hours. So you've got to set up in hours contact, after hours contact, that has to be set up before you start in your region and work it out with the LHD.
Thanks, Wally. And Kerry's got a question in the chat. Who do patients contact after hours in Western New South Wales LHD? And look, the answer to that would be that the expectation is that practices have got something lined up. Is we're not in the same position as Sydney Children's Hospital to have a large workforce potentially sort of providing that after hours service. So the expectation is that the accredited general practices who would normally have an after hours set up already, that is perfectly adequate to function as your after hours service for your COVID positive patients. Also got a question here about how does Western PHN plan to get oximeters to the patients by post? Christy, did you want to talk to that?
Yeah, hi Ivy. Yeah, so basically the PHN has got a plan to use the post. We'll be using probably a courier system. So we're still working around that and how that will look, or we may even be able to supply some pulse oximeters to some key surgeries that, as a bit of an emergency supply. But we do understand that transporting of oxygen SATS probes might be an issue in some areas, especially in the far west. So we're still working on that at the moment.
Thanks, Christy.
Someone's got their hand up, Avi. Alex, is it?
Certainly is. Alex Gannam here from Mudgee. We'll be running a GP respiratory clinic until at least the end of June in Mudgee. The expectation is that we'll be providing some COVID care in the community. Tell me about what happens with any face-to-face consultations for patients. I guess we have the idea that perhaps they may need to be seen and we can see them off-site in our clinic in PPE in between our respiratory patients, just to reduce the load on ED and reduce the risk of cross-contamination. Because as you can imagine, Walid, we're not just working in the general practice, we also work as VMOs in the hospital and sometimes in the ED itself. So we're acutely aware of the impact of what that means for our hospital if we were to have an outbreak.
Yep, absolutely. I think so. I don't think there's any expectation for most general practice to see patients face to face. You can if you want to, of course, if you're set up and you've got all the gear and you've got the reduction and all the sort of measures to reduce cross contamination set up. And I think as respiratory clinics, I mean, I don't know your setup, but I imagine part of the deal was that you are set up in that way and that you are ready and able to see patients face to face. That's why you're a respiratory clinic. And so that's great. I think you're set up to do both. I think you would be a wonderful experience. But 98, look, I think that don't overestimate the number of people that need face-to-face care in this cohort. Again, we're talking about low to medium risk patients. I can seriously count on one hand the number of patients. As I said, we've just looked, we're over 100 kids at the moment. We did about 20 adults, plus we had our own patients who had COVID early in the pandemic, which we were looking after before everything was set up. So in the last 2 years, I can think on on one hand, the number of patients who I thought, gee, I'd love to listen to your chest, or someone really does need to listen to your chest. Because by the time those patients, particularly with Delta, and it is a concern that they can rapidly deteriorate, let's say it, let's face it, we need to be aware of those risk factors. Someone whose oxygen's dropping to less than 90%, you're not going to be wanting to see them at a respiratory clinic. You're not going to do anything for them. You're going to get them to hospital. So the idea is it's more the, to be really honest, it's the post-acute illness that really needs face-to-face care. But by then they're not infectious anyway. So that's my experience. Mel, I don't know whether you want to add any expertise to that.
Well, our numbers, we saw when we crunched our numbers, our first 1,000 patients, so that was 77% were unvaccinated, and about half were kids. So 100 of those needed to go to hospital. So 10% needed to go to hospital. And then of those, something like 6.5% ended up actually admitted to hospital. And then a significant percentage of those went to ICU. So even that's in a predominantly unvaccinated population. Then if you break down the kids from that group, something like 4 kids needed to be reviewed in hospital and 1 child out of 700 or something like that.
Yeah. So,
I remember the numbers of the kids. 1 kid needed to be admitted. Yeah. And that was a pretty vulnerable population we saw initially because of just the nature of how Delta got in. So I would hope that they wouldn't need a review. The one thing is, Alex, though, and I guess this is something to think about, is the ones that you may want to give sotrovimab, which is a new treatment that's useful in the first 5 days of illness for people who are on that sort of moderate to high risk. And at the moment we were sort of planning to do, being the LHD would be notified and we could organise sotrovimab in hospital, but possibly that's something that we could do with the respiratory clinics. And in that case, you do need to have a face-to-face consult. But again, I'm not sure because, again, I don't know how the billing would work for that, but something to think about.
Yeah.
Mel, we could make that happen. It wouldn't be a problem having an IV in a clinic. We've got nursing staff there. We can work around the billing. I don't see that as an issue. We just need a protocol and probably work that out with the area health service.
Yeah, well, let's chat about that, because I think they'd be very interested in that. Let's have a chat. Definitely.
Okay. Thank you.
And Mel, I think the other type of patient who you've mentioned has needed to be seen face to face are the COVID plus patients. Can you talk to that one?
Yes, so that's true. Absolutely. I didn't mention about the COVID plus. So inevitably that a child that has COVID also has a lot of energy and tends to break things themselves, as in like they break bones, and that becomes quite an issue. And adults often get, you know, their AF plays up or something else other than COVID happens. And so a lot of those have had to go into hospital, you know, because they did an X-ray, for example. And again, what we've done, you know, so far is we've been a bit of a conduit to try and arrange that X-ray as quickly and also to sort of minimise cross-transmission in the hospital. So, you know, well, if there's a child that needs an X-ray but it's clearly not urgent, then what we'll do is we'll talk to the parents, arrange the time, tell the radiographer, make sure that we've got this sort of clear transport straight in, get the X-ray goes out, so that there's none of that sort of waiting in the waiting room, haven't mentioned to anyone that we're COVID positive, and then there's like, you know, the whole contact tracing that goes on. So that's certainly something that I think that the COVID care in the community can be a bit of a conduit, because we sort of know, particularly at the base sites, but I guess like at the smaller sites, like a lot of the GPs actually work at the hospital. So it's just about thinking about how you're going to bring that patient in safely and to minimise transmission.
Thanks, Mel. And so for our larger towns where we are needing to facilitate that, written into Health Pathways, if you go into the request page, and by the way, I'll pop the link and username and password into the chat soon. But basically it's in Health Pathways. There's a 1-800 number, which is the COVID care in the community team who can facilitate that entry into hospital, but there's also a mobile phone number which will be manned by Mel or one of the other 3 COVID consultants, so that if we are needing advice, if we're feeling a little bit out of depth with a particular patient, we can call that and get direct advice from one of the 4 COVID consultants.
I mean, I don't know, Mel, you may want to sort of, as I said earlier, I think as GPs, we don't want to trouble you with minor things, so maybe you can have 2 channels of communication. One is the mobile phone for urgent things that are clinically relevant, and something else for administrative issues like, hey, is day 0 this or day 0 that?
We have the 1-800 number, which is manned. Well, currently it's manned like 24 hours, but we probably, as Wally was saying, you don't get calls after 10 o'clock from patients generally. And if people are getting calls at 10, they need to go to hospital. They're generally getting sick. So we're sort of reviewing and thinking that we'll probably provide the hours between 8 a.m. and 10 p.m. So for things like, I'm a bit confused about the de-isolation, or, I mean, I think what we'll do is we'll sort of map it out a bit to say, you know, if you really urgently need some clinical questions, that'd be like something that you'd want to call me up. And early on, I'm being very happy to take as many calls, and that's what we've done. So there's GPs working in COVID care in the community, and whenever anyone comes on, are just like, you know, just calls about anything. But with the 1-800 number, that's a really useful number for, what do I do with this de-isolation? How do I get, you know, services? What about drug and alcohol? Those kind of things. You know, because I mean, a lot of this stuff is not about COVID. It's about all the other services, because what happens is it just opens a door to someone's house, and whatever social conflict is going on or the things that are bubbling under the surface, 2 weeks in isolation certainly brings it all up. So and how I would sort of approach it.
Yeah. This may or may not work for you, but what's worked for us at the Children's Hospital and actually the adult hospital when we're doing it there is having a central email, like an email address to email some non-urgent questions. Anyway, that's something to think about. Just like
we have that.
Yeah.
So we have I've got the email, which is manned. We also have a, if you discover a patient that you want to put onto the service, we also have a text messaging service, but we'll kind of give them all to you and you can use whichever one you feel is most appropriate.
Thanks for that. Debbie had a question. I see a potential issue with larger town after hours cooperatives where some doctors may not want to be involved with looking after COVID patients. These co-ops need to be consulted about this, not have this imposed on them. Any solutions? I think that's a really good point, and it's absolutely on Christie's to-do list to, in particular, liaise with the Dubbo After Hours group and the Bathurst After Hours group. If there are other groups that, I guess COVID care in the community and PHN need to liaise with, let us know. But I think if there are GPs within those groups who feel nervous about looking after COVID patients, I think, going back to Wally's comments about the fact that, these by definition should be low and medium risk patients, the likelihood of them getting into trouble in the after hours period and calling on additional help during the after hours period is small. But if those people are calling during that after hours period, chances are that they do need to be escalated to get a hospital assessment done. But yeah, absolutely, there will be discussions happening. Did you want to add anything else around that, Debbie? Feel free to unmute yourself if you want to.
That may not be a good idea, my unmuting myself. Can you hear me?
Yes.
Oh, okay. Yeah, look, I do see that as being an issue. Now, the other thing is, that's 48 hours across the weekend. The after-hours services will get used for sure. So we really do need to do something about that.
Yes, so that's there. And Debbie, I'm really sorry, I'm not sure where you're located.
Bathurst.
Bathurst. So if we kickstart with the Bathurst discussion, do you guys meet up with the Marathon Health group, same as we do in Dubbo?
Every quarter.
Okay,
but
not very often.
Even then, not a lot of doctors attend. There might be 3 or 4 regulars.
Yeah, right.
So, yeah, I think it could quite be an issue. And Jamal, I'm interested in what you say. What do you guys do? Do you provide care over the weekend? Is it?
That's a good question.
But is your practice open on a weekend? Because we're practices, we're not open on a weekend.
No. So we're open Saturday mornings, just till 12, and that's it. So yeah, look, that was certainly one of the major things that we had to work out amongst ourselves before we decided to take this on. Is this going to be a 24-hour-a-day, 7-day-a-week commitment or not? As it's turned out, again, both with the adults and with the children, the answer is no, it's not been a 7-day week, although I've left it a lot to each individual clinician. So the basic expectation that it's not, so it's in-hours care, and then the patients have a 1-800 number to call if they are worried, and that's manned by the Children's Hospital.
Yeah.
So that's the default, right? But we have most of our doctors and most of our team have actually said, no, you know what, I am, for continuity of care, I'm going to ring you tomorrow morning, being Sunday morning, to make sure you're okay, because I'm a little bit worried about your child's headache and fever. So I've found that, yes, most GPs in our practice have actually not needed to, but done it because they wanted to. We're talking about one phone call to a sick child or a couple of sick kids. It takes 15 minutes at the most. We've all got remote access to their files through the internet. We've even done video calls after hours using our platform. But that's not an expectation. I don't want you to think that it is an expectation, but it was really, I must say, satisfying to do, to provide that continuity and reassurance to these families. And a friendly phone call on a Sunday may not go astray.
Hi, Kerry's just written in the chat about what about towns in Western HT that have no after-hours GP at all? do COVID patients contact the local MPS or the Western LHD COVID number? So I think it's probably a case by case, but certainly, I mean, I think I was saying, you know, if you've got a single GP in a small town, it is entirely, or even 2 GPs in a small town, it's entirely unrealistic and not fair to say, okay, well, here you go, manage your 2,500 patients, all that could become COVID positive. So I think that the LHD recognises that there will be some work together about, you know, a strategy to help and support. Unless the PHN has another idea that they would prefer, that would, I'm sure, I think we'll probably foresee that we'll land at that. Ivy, do you have anything to add to that?
Yeah, I was just going to see if Andrew's there. Andrew, the role of Health Direct in all of this, could you perhaps elaborate a little bit more for our group?
Yeah, sure, Ivy. Look, I think the arrangements with Health Direct are still fluid, and I think this is sort of where we are as an as a sector, and I think it needs to be landed. I mean, at this stage, the idea is Health Direct will make contact with the patient, and there is a possibility that Health Direct will provide a telephone support function, both in hours and out of hours. I think what Mel said before is probably where we need to be across the region, in that we need to come up with a solution, and where we have gaps to fill, we can either ask Health Direct to fill those gaps, or the PHN can commission other providers to fill the gap. But I think what Waleed said earlier is really, really important, in that, you know, the perception is most of these people will be able to be managed during the day and won't need much support after hours. And as you said, Mel, you know, the default position may well be the LHD out of hours, but well, one would hope that the majority of people could be managed during the sort of working day, with the option, as Waleed said, is that some GPs may want to check in on the odd patient over the weekend because they just want to make sure the patient's safe. Does that answer the question, Ivy, do you think?
Thanks for that, Andrew. Yeah.
Yeah, look,
So I guess
Health Direct's role is still very fluid as of today. So
Yeah, that's right.
stay tuned. That's why I've said, don't worry about how you're getting the patients yet. Just don't worry about that. It's too complicated.
Yeah.
Just work out whether you're going to get them and you want to take them. I think as a general practice, you need to work out whether you want to be part of this, because you want to be part of this, you're going to be part of it for your patients, for other patients, and how you can really, really, really build a relationship with your local health district team, acknowledging, of course, that in many of your regions, you are your hospital team. So you know, I'll leave it at that, I think. I'm sorry, Mel, I interrupted you.
No, there's a couple of things. So Debbie said, where do we stand for medical defence? So the good news is because we've been doing a lot of virtual consultations, there's some pretty good medical defence that's now been laid down. So you just need to speak to whoever your provider is to ensure that you've got the right cover. And that should happen just before you start to see any patients virtually. But there is good defence cover for these interactions now. What Terry's saying about parts, so that's very interesting. And I think, you know, that obviously requires a discussion with my bosses in the LHD. Because that's a huge population. I mean, what we don't want to do. I mean, I'm an emergency physician, right? So here is what I think that COVID care in the community does. Firstly, it finds you sick patients. Secondly, it supports patients with COVID, which is a scary new disease. And thirdly, it hospital avoids. So if we've got an uncovered service in the afternoon and the evening, totally understandable. I completely understand that rural and metro are very, very different spaces. Then the LHD will, you know, we'll have to work with that, and that's the way it will be. But it's something I'll definitely raise with my Director of Ops tomorrow. It's a really good example.
Yeah, and look, I'd add to that, Mel. I mean, I think what we're trying to do here is identify the areas where we've got a problem, a potential issue. So I think what we're trying to do is start in the beginning to say what populations have got coverage from primary care? Where is that really strong? What do we need around making sure there's an after-hours solution? And I think we've talked about that tonight. Excuse me, but Kerry, as you've identified, if we've got a particular LGA, a particular town where there is either limited or no coverage, then the PHN will work collaboratively with the LHD to come up with a solution. Now, that may well be a practice that is local. It may be another practice in the next town across that can provide that coverage. But we'll work on that process as we start to identify which practices are able to offer a service and which aren't, and where the gaps are.
And I guess the wider conversations that have happened around that, there's at a Commonwealth level, there's been discussions about the possibility of Health Direct not just being that initial triage process, but potentially being providing care for COVID positive patients. And look, the discussions that have happened with different practices and LHDs, our 2 LHDs across our wider footprint, I guess there's a level of concern there that there might be someone sitting in Metro not having any clue of how things work out in Western world, and making recommendations that just not feasible for our patients. So I guess the other things that have been looked at in terms of possible solutions are a similar track, is there a deputising service that PHNs can come together to commission that will, I guess, also likely be someone from outside of the area providing care to our patient cohort. Then we've looked at, is it a possibility of some practices who may have a little bit of extra give, and that may be more likely the larger practices in our larger towns who may have that little bit of extra give to then take on a little bit of extra COVID positive patients and babysit them for that 14-day period, and then hand them back to the usual general practice in another town or even in the same town. So those are some of the discussions that are taking place. Yeah. And I guess at the end of the day, what are we trying to aim for here? It's a horrible pandemic that it's just been so much work for everybody for the past year and a half. We're all exhausted. But it's outside of our control. So the prediction absolutely is that we're just going to see big numbers somewhere in the not too distant future. And absolutely, we need to protect our hospital teams, because if that they haven't got the capacity to be able to cope with the volumes, like even what we've seen in the outbreak that's passed, because that's hasn't it, Mel? It's involved pulling so many people from all different jobs, so that a lot of services have just not been able to function because these people have landed in the COVID care and the community team. And that's not something that's sustainable down the track if we want to be able to have hospital services running in some way, shape or form. So I guess it's a balance between all of that and what we can contribute to the system as a whole as well.
I think there's a few things that we should unpack. So Alex has just said, would VRGS be able to provide the service? Look, it's possible, Alex, but I think, to be honest, if VRGS was going to step into the space, it probably would just use the CCIC, because the VRGS are pretty busy as it is.
What's VRGS?
So the virtual rural generalist service. It's a virtual GP service that provides care in hospital. So it's possible, but I think probably what happened is we'd enhance the CCIC or a combination of the two. Just in terms, I think there's a few things about this disease. So firstly, and I'm sure everyone's aware, I don't think this is going away ever, really. So this is going to become endemic, and I can't see us looking after patients like the way that we're describing ongoingly forever. I think what will happen is it will morph into a far less hands-on, but unfortunately where we sit at the moment, where we're still treating it as everyone being highly infectious and requiring isolation, we do have to provide this service where we're looking after people within their home and they can't leave. But I feel at some stage we'll get to the point where, and I did mention this to the public health unit, at which point do we say, well, everything's open and, you know, it's been going on for a year now. Is there much point to constantly isolating everyone? Because this is not something that's going to go away. So I think we'll start with this process, but I feel like it will very likely change over the next few months. The next question was about, what about young siblings who develop symptoms? Okay, so there's a very clear process. So once a young sibling develops viral symptoms, they would need a swab to support that they are either COVID positive or COVID negative, and undoubtedly they would be COVID positive. So we know that Delta patients generally go positive and the whole family goes positive. And in terms of returning to school, this is in the HealthPathways, we don't support re-swabbing patients after they've gone positive because they invariably still positive and can be positive for months. So we don't swab for return to school, we don't swab for return to work. What about the gaps over Christmas and New Year's? To be honest, I think that's almost exactly the same as the issues with a loss of after-hours service or an inability to have after-hours service. I think it all kind of packages in together. We've been really pushing with Health Direct. So to make it very clear, Health Direct comes from a Commonwealth initiative that has been layered over the top of the New South Wales health work. And they are pushing to start it before Christmas. And I think all of the people that work within this service currently realise that that's a pretty crazy time to start anything new, because everywhere, hospitals, P's, everywhere goes on a slow road for the 2 weeks, and they want to start it 5 days before the 20th. They want to start on the 15th of December. And so, I mean, it's an interesting time to start. And I think that today we asked them for a bit of a roadmap and a timeline. You know, I think if you're planning on like a soft start with a bit of a trial phase, that's one thing, but to completely start an entirely new initiative before Christmas seems like you're just damning it to fail. How would families access pulse oximeters? Is it 2 weeks? How long? Oh, they just require it for the 14 days if they're unvaccinated.
Well, at this stage, from the PHN perspective, the thought is that it will be a no return oximeter. So the likelihood is that if it's coming from the PHN, it will get sent to that family and they keep that oximeter then. And
Yeah,
Sarah?
and it's Christy. I was just going to say, and around that, it's just we haven't worked out the process about the high risk of cross-contamination and it coming back through the post, the PHN being a non-clinical space to be able to do the appropriate infection control around those devices. So at this moment, I think that probably is the easiest for everyone and the safest as well.
Thanks, Christy. Sarah's got a great question about the proposed monitoring platform, and particularly if practices are helping to look after patients from elsewhere. Have we got Claire? Andrew, thanks.
Yeah, happy to talk to that. Ivy, look, I think we've looked at a couple of options. We're hoping to land a final solution this week and to have a rapid implementation. I mean, what we need is a platform that everyone can access. So whichever way we go, we'll be looking at a platform that the appropriate clinicians can access clinical data. Ideally, it will be a situation where it's populated from clinical management systems, whether it be a hospital system or a primary care system.
Are there any other
Sarah
questions?
here again, rather than typing, I was just going to say, is there any place for the My Health record in this data?
I think that's a very good question. To date, I think people have suggested that the My Health record is insufficient for what people need, and what they need is a real-time tool that they can add information as they see it needing to go into the system, and then people see that information quickly. Claire, did you want to add anything more?
Yeah, thanks, Andrew. Sorry, I did just want to add something on that. So, Sarah, just to give you some background on that, it is essentially the platforms that we're looking at is going to be able to provide that real-time clinical data to all members of the care team. So that is something that we're considering in our evaluation of which tool we actually do choose. And as Andrew said, we're very close to actually landing on a decision. But essentially, it will be a platform that as a GP, you'll be able to log into and assess essentially a dashboard so that you can monitor your patient's clinical observations and be able to have the patient doing self-monitoring at home so that that will then feed through to the dashboard and you are able to assess the patient's clinical progression and whether or not they will need escalation to an LHD team or not.
Yeah, so look, I think, so one of the things that we've been playing with is similar. We haven't actually taken it up yet, but we're looking for it to a couple of refinements on it. In an ideal world, if you think about hundreds of patients or thousands of patients, most of them low risk, most of them self-monitoring, they enter their data on their phone, be it the oximetry, their pulse, their blood pressure, or whatever they're monitoring, how they're breathing. And it comes up on a dashboard so that you can target your phone calls to those that need you, right? So that would be an ideal situation to set up, and those platforms exist and need to be refined, but nevertheless they exist. So that's at a practice level, and then you can draw in different team members across multiple sites, including integrating with the LHD on this. So the technology's there. It's just a matter of trying to sort of streamline it and refine it across the board. There's a final question, sorry, about billing. Debbie, I think, yeah, you wanted to ask about that. Is that right?
Yeah, so just picking up on that question about billing for seeing these patients. So that would be using the existing, if you're doing a video consultation with that patient, you bill the video consultation item number. If it's a phone consultation, bill the phone consultation. Just bearing in mind that if somebody is COVID positive, that we don't then have to work to that rule of having seen that patient face to face in the past 12 months. So that's a little bit of a bonus there. So yeah, just use those existing item numbers. Now there is no requirement, no mandate to have to bulk bill these as well. And we've certainly talked with GPs in the Sydney footprint where, their practice is normally private billing and the patients normally come through and used to having private billing, and so they've continued with that. So it's entirely up to individual practices to work that out with their patients.
Yep, so that's right. So the Medicare exemption, so patients who are isolating because they're either close contacts or they're actually positive, have to isolate at home. It's Medicare. You can bill the normal Medicare items, including the long telephone consultation, by the way, which also exists for those patients and hasn't been taken away. So it's telephone or video as per normal. And on the billing issue, look, it's entirely up to you whether you privately bill or bulk bill. No one's forcing you either way. I think, though, to be, and this is my own personal opinion, we've bulk billed these patients, even though none of them are our patients, or some of them are, but most aren't. Only because, again, we over a 14-day period, multiple children, multiple family members, multiple interactions, multiple billings. I think it is probably and these are patients who are isolated, wondering how they're going to get their food deliveries, etc. There is a social impact here. There's a psychological impact here. The last thing that we decided we're going to do is impose a financial impact. But that was our decision as a practice, not imposing that on anybody else. The last question is, have you utilised nursing staff? Yes, so absolutely, we have. Now the problem is that we don't get paid for nursing staff. Or no, let me rephrase this. In the pilot that we're doing with the Children's Hospital, to be completely transparent about it, the PHN is funding the nursing calls because there is no item number for it. When a doctor has a clinical interaction by telehealth, we bill the MBS. When a nurse has a clinical interaction with these patients, we send the bill to the PHN. That's something that we've done locally. That's not something, again, I'm imposing on you, but that's an ideal model, I think, a blended model. But nevertheless, it's something that we've managed to do locally. And is it a time-saving thing for nurses to do it? Absolutely. Absolutely. There's no way I'm ringing every patient for 14 days in a row, nor am I expecting to do that, nor do they need it. Most of them don't need that. But so I'm introducing the nurses, and I'm then booking them in for nursing calls, and I get dragged in when I need it. So we'll kind of share it.
Sarah, in terms of a couple of comments there, so the dashboard platform, concerns about that being a medico-legal risk situation, it would be entirely up to individual practices whether they do want to make use of a platform or not. The PHN is certainly providing supports where it can in terms of funding a platform, and it's my understanding is that it's drilled down to 2 platforms at the moment, whereby it will actually cut the workload a huge amount for practices if patients can actually put their symptoms and OBS onto the platform, but there wouldn't be any mandate to have to use those platforms. In terms of our PHN potentially accepting invoices for nurse time, there's been some discussions, and I think there's going to be some sort of work done into what that could potentially look like and where funds might be able to come from. I don't know if, Andrew, you want to speak further around that?
Yeah, look, I think that's right, Ivy. I mean, I think we're all in this together, and I think we need to work out what's going to work best. I think if there is a potential to use nursing resource in a different way, if that's going to cause problems from a sort of Medicare billing point of view, PHN is really willing to look at that. I mean, what we talked about earlier today was how we might model that and provide that information to practices. So I think it's a work in progress, Ivy.
Thanks, Andrew. Just looking at time, it's just a few minutes past 7:30. Were there any final questions? Thank you, everyone, for jumping in on an evening after a busy day of work, and for the rich discussions that's taken place. This is an evolving journey. There's so many bits of the puzzle that are being revealed as time goes on, both at a Commonwealth level and at a state level. And certainly we're doing a lot of work behind the scenes to try to put things into place that will make it as easy as possible for hardworking GPs and our GP shortage in our region. Handing over to you, Katie.
Thank you so much, Ivy, and to all the panel. That's been really excellent and lots of questions addressed there. So that's wonderful. We've just got a bit of a survey there that if there are any other questions, any other needs or support you feel like you need, please take a few minutes to just do that survey. Let us know what you want covered in future meetings or what future support you're requiring, and we will certainly do our best to bring that to you. There's also some questions around more regular meetings if you find this useful in an ongoing fashion. So if you have just a couple of minutes, please do that survey. But thank you all so much for your time. We realise how busy everyone is and how precious your time is. Thank you all for your work, and we hope to see you really soon. Take care.
Thank you.
And thanks, Wally. It was lovely to have you.
No problem. Thank you. Thank you, everybody. Bye.
Thanks heaps, Wally.
Bye.
Catch you at a VCOP meeting.
Bye.
Thanks, Ivy. See everyone.
Thanks, Katie. See you, everyone.
Thank you all.